Tobacco smoke doesn't just increase cancer risk, it drives it at the molecular level. Understanding how helps us make sense of why there's no safe level of exposure. We all know that smoking causes cancer, but the real question is how? How does something that feels so ordinary, like lighting up, translate into something as complex and catastrophic as cancer? Well, it starts with the contents of the smoke. Every puff delivers a cocktail of more than 7,000 chemicals, and at least 69 of these are known carcinogens. These include substances like benzo, pyrene, NNK, formaldehyde, and arsenic. Once inhaled, these compounds are metabolized in the body and transformed into even more reactive forms. They bind to DNA, forming what are known as DNA adducts. This damages the genetic code, and if the body doesn't repair that damage properly, mutations start to accumulate. Now, not every mutation leads to cancer, but certain mutations, like those in the TP53 gene, which controls cell growth and repair, are especially dangerous, and these are precisely the kinds of mutations that show up repeatedly in smokers with cancer. That's just one mechanism. Others include epigenetic changes like gene silencing through methylation. Smoking can switch off tumor suppressor genes without changing the DNA sequence at all. And then we have oxidative stress. Cigarette smoke is full of reactive oxygen species, free radicals that cause widespread damage to DNA, proteins, and cell membranes. This kind of damage lays the groundwork for cancer to take hold and spread. So what kinds of cancers are we actually talking about? So let's go through them, this time with some added context. Lung cancer. Still the most well-known. Around 85 to 90% of all lung cancers are caused by smoking. It's the biggest killer and often diagnosed late. 2. Bladder cancer. Carcinogens are filtered by the kidneys and stored in the bladder, exposing the bladder lining to concentrated toxins over time. 3. Esophageal cancer or gullet cancer. Smoke directly irritates the esophagus, and combined with alcohol, the risk is even higher. Squamous cell carcinoma is the main subtype here. Pancreatic cancer. Smoking is one of the strongest modifiable risk factors for pancreatic cancer. It increases the risk of both exocrine and endocrine tumors of the pancreas. Cervical cancer. Smoking doesn't cause HPV, but it weakens the immune system's ability to clear the virus and damages cervical cells directly. Kidney cancer, especially renal cell carcinoma. Smokers have about a 50% higher risk than non-smokers. Stomach cancer. Smoking increases the risk for both cardia and non-cardia types of stomach cancer, partly by contributing to chronic inflammation. Liver cancer. Smoking is an independent risk factor for hepatocellular carcinoma, especially in people with hepatitis or alcohol-related liver disease. Oral cavity cancer, including lips, tongue, and inside the cheeks. Smoking and often chewing leads to direct repeated exposure to carcinogens. Laryngeal cancer often presents with hoarseness. Smokers have a 10 to 15 times higher risk than non-smokers. Pharyngeal cancer. This includes the nasopharynx, the oropharynx, and the hypopharynx. Again, smoking plus alcohol is the deadly combo. Acute myeloid leukemia, a blood cancer, not what people typically associate with smoking, but exposure to benzene in smoke increases this risk. Ureter cancer. Like the bladder, the ureters get exposed to filtered carcinogens and are at higher risk in smokers. So the damage isn't limited to the lungs. It's systemic, it's chronic, and it's cumulative. And just to be clear, there's no safe level of smoking. Even low-intensity smokers, say less than 10 cigarettes a day, still carry an elevated cancer risk. Now let's talk secondhand smoke. People exposed to secondhand smoke regularly, especially over years, also show elevated risks for cancers, especially lung, breast, and nasal sinus cancers. And children exposed early in life may carry long-term increased risks. And what about third-hand smoke? That's the residual nicotine and chemicals that linger on surfaces and fabrics. It's less studied, but evidence is growing that these compounds can still pose a cancer risk, especially in children. Let's not forget time matters. The earlier a person quits smoking, the more risk they recover from. Quitting before the age of 40 avoids up to 90% of the excess risk for cancer-related death. Even after a cancer diagnosis, stopping smoking improves outcomes, reduces treatment complications, and lowers the risk of recurrence. So what does this all mean for clinical practice? Well, first, we need to move past the vague "smoking is bad for you" conversation. We need to be specific. If a patient has a family history of pancreatic cancer, explain how smoking compounds that risk. If a woman has persistent HPV, explain how smoking may prevent her immune system from clearing the infection. Second, reinforce that light or social smoking is not safe. The damage doesn't only come from heavy long-term use. There's no magic number under which risk disappears. Third, this is a great time to talk about risk perception. Many smokers underestimate their personal risk. Tying their habits to real-world examples like their aunt who had bladder cancer or their hoarseness that hasn't gone away can make the risk more real. Finally, this is a public health issue. We should be advocating for continued investment in anti-smoking campaigns, plain packaging, and legislation that limits exposure to secondhand smoke. Cancer is one of the most feared words in medicine, and tobacco remains its single most preventable cause. We can't undo all the damage, but we can stop the progression, and every day without smoking is a step in that direction. In our next episode in this smoking series, Smoking and Cardiovascular Disease, a Rapid and Deadly Link. That's all for today, folks. My name is Dr. Fergal Armstrong, and this has been Cracking Addiction.